Good afternoon. My name is Shayma Kazmi. I'm a thoracic medical oncologist. I work at Penn Medicine Cancer Center in New Jersey. I'm sorry I'm unable to be there in person today, but the weather just wasn't having it. So hopefully you will be able to get the same information with my recorded talk. I will discuss adjuvant therapy updates in non-small cell lung cancer today. There's not a ton of dramatic updates like there have been in the past few years, but I think it's always a great idea to review the information that has really exploded over the last few years and consolidate and really digest it slowly. So just as a way of setting the stage, the adjuvant therapy really has been established for almost 20 plus years, and it's a cisplatin-based doublet chemotherapy regimen for all non-small cell lung cancers that are stage 2A or greater after resection. We do consider these therapies in patients with stage 1B that have high-risk features, large tumor, pleural invasion, and so forth. So there are certain patients with stage 1B that may warrant adjuvant chemotherapy as well. So this is the current NCCN guidelines for both neoadjuvant and adjuvant therapy. As you can see, preferred non-squamous is cisplatin pemetrexed. The squamous regimens can be cis-gem or cis-docetaxel. And there's multiple other aberrations. You can use vinorelbine, etoposide, paclitaxel, and of course, on the bottom is the new addition that we've had based on a couple of new landmark trials, osimertinib based on the ADAURA clinical trial for adjuvant patients who harbor an activating EGFR mutation, specifically exon 19 deletion, L858R mutation, stage 1B to 3A, who have had resection, who may be eligible for chemotherapy, or even if they're not eligible for chemotherapy, warrant 3 years of osimertinib therapy in the adjuvant setting. Empower 010 showed us that atezolizumab, which follows chemotherapy in patients stage 2B to 3A, or certain high-risk 2A patients who are PDL positive, and that duration is 1 year. We'll discuss both of these trials and their data. So again, just as a look back, the British Medical Journal had published in 1995 this big meta-analysis that showed the benefit of adjuvant cisplatin trials and showed a 5% overall survival at 5 years. And really, this was 52 randomized clinical trials. And since then, this has remained the mainstay of adjuvant therapy for that many years. So getting right into ADAURA, we talked about this a little bit. So we know that 30% of patients with non-small cell lung cancer have resectable disease at diagnosis. And standard of care, we know, consists of surgery, usually a lobectomy, followed by adjuvant cisplatin-based chemotherapy in patients with stage 2 to 3A disease, and in some patients, as I mentioned before, with stage 1B disease. But despite adjuvant chemotherapy, there's improvement in overall survival and disease-free survival. The recurrence rates are still fairly high, unacceptably high, ranging from 30 to 70%. So we know that osimertinib is a third-generation EGFR tyrosine kinase inhibitor. It's been approved for treatment initially for EGFR mutated T790M positive patients, and then frontline for patients with stage 4 relapsed EGFR mutated non-small cell lung cancer. We know that the activity and safety profile in late-stage disease suggests that there is definitely potential efficacy in early stage disease. Current unplanned interim analysis of phase 3 ADAURA trial compared adjuvant osimertinib versus placebo after complete tumor resection and adjuvant chemotherapy in eligible patients with stage 1B to 3A EGFR mutated non-small cell lung cancer. So this was the study design. This was a big international trial, randomized double-blind phase 3 trial, and the data cutoff for interim analysis was 2 years ago, January 2020. They did recommend early unblinding due to the efficacy. At the time of unblinding, patients had over 1 year of follow-up, and really trial had completed enrollment. So patients that were enrolled were completely resected stage 1B, 2, 3A non-small cell lung cancers with negative margins, non-squam non-small cell lung cancer, EGFR exon 19 deletion or L858R mutations, adults age 18 or over, or 20 or over in Japan and Taiwan with good performance status, with no baseline brain metastases with imaging. Adjuvant chemotherapy, of course, was permitted. They were stratified based on stage 1B versus 2 versus 3A, and also based on the type of EGFR mutation, also their race, Asian versus non-Asian. And they were randomized to receive osimertinib 80 milligrams daily versus placebo daily. And the follow-up, the duration was 3 years, unless there was recurrence or other discontinuation criteria met. So the primary endpoint was investigator-assessed disease-free survival in patients with stage 2 to 3A disease. And again, the trial was designed to test superiority, and the hazard ratio was set at 0.7. Secondary endpoints were disease-free survival in overall population, which included 1Bs as well. And then landmark disease-free survival rates at years 2, 3, 4, and 5. Overall survival is also going to be measured. It's going to take some time. And then, of course, quality of life and safety. So based on characteristics of these patients, predominantly female, 2/3, median age. Again, we could see that there are a lot of young patients here. Median age is almost a decade younger than patients who don't harbor these activating mutations, so in the 60s. Some smokers, so a quarter to a third of the patients were smokers, so we can assume that this is a disease of non-smoking population. 2/3 were Asian, mostly great performance status. A third 1B stage, a third stage 2, and a third stage 3A, mostly adenocarcinomas. The others might have been mixed histology. And then the ratio of the EGFR exon 19 deletion versus L858R is about half and half, and 50% or over received adjuvant chemotherapy, and so 45% did not. And of course, that's a question that comes up a lot. So we'll get into that. So the disease-free survival curves, I mean, this is dramatic, right? You can drive a truck through these Kaplan-Meier curves, but you can see this was patient stage 2 and 3A. You can see that the median disease-free survival for placebo arm is 20 months. For the OC, it's absolutely not even reached. And that hazard ratio, remember their goal was 0.7. This is 0.17. Maturity was only about 33% for the OC arm at the time that this was reported. So still early, but we have ways to go to establish the real superiority here. But no question that this really, adjuvant osimertinib significantly prolongs disease-free survival versus placebo in stage 2, 3A disease. What about overall population? So when you include 1B in it, not much different. So there's still a dramatic benefit in those patients, has a ratio of 0.21. Again, disease-free survival, the median has not been reached with OC, with placebo's 28 months and still relatively immature. When you look at the subgroups, we're interested in making sure there isn't a subgroup that does not benefit from osimertinib adjuvantly. And you can see male, female didn't matter, age really didn't matter, smoking, non-smoking status didn't matter, Asian, non-Asian. You can see that the line for stage 1B does approach 1, but it's still well to the left. So the benefit in earlier stages may not be as dramatic as stage 2 and 3A, but it's still measurable and is still statistically significant. The type of EGFR aberration didn't matter in terms of efficacy significance, but you can see that the exon 19 deletion tends to do even better with OC than the L858R, which is a more difficult disease. Whether the patients had adjuvant chemo or not didn't make a difference in efficacy of osimertinib. So here you can look at it by stage. Of course, stage 1B, the curves are a little bit closer together, but as I mentioned, the hazard ratio is 0.5, still significant, and we'll continue to follow this. Stage 2 and 3, we could see a dramatic difference, has a ratio of 0.17 and 0.12. Early overall survival, really hard to know yet. I mean, the maturity is 5%. The curves are beginning to separate, but this is going to be continued. Hazard ratio is coming up at 0.4 now, but we have ways to go to really assess whether this makes a difference in overall survival, given that the patients who may relapse have the option of osimertinib in the frontline setting and maybe even more advanced TKIs thereafter. So we'll have to see, and also the resistance patterns that develop in patients who do relapse who've had adjuvant osimertinib. So a lot of unknowns there, and I think we'll have to see how this plays out. Safety-wise, of course, we have to consider when we're talking about adjuvant treatment, and for 3 years, what's the tolerance level? So really, with the osimertinib, you can see that greater than 3 AEs, 20% versus 14% in the placebo arm. Serious AE, 16% in the OC arm versus 13%. So AEs leading to discontinuation, 11% in the OC arm. So not a huge number, but not zero. So this is certainly something to consider, that not all of our eligible patients will be able to tolerate this, handle this for 3 years, or continue it. Dose reduction was done in 7%. So possibly causally related AEs, we see that the numbers are a little bit lower, but still greater than grade 3, 10% in the OC arm. So there was a grade 1-2 ILD that occurred in 3% of patients receiving osimertinib. That's certainly something to keep in mind. There was 1 death in the placebo arm due to a grade 5 pulmonary embolism, and then some QTc prolongation that we don't usually monitor patients for in the metastatic setting, but something to consider if they are on other drugs or have cardiac disease. So all causality AEs just highlighted here. You can see diarrhea, paronychia, dry skin, sort of skin things are more common with OC, but mostly low grade and small numbers. So the conclusions, of course, are that osimertinib significantly prolonged disease-free survival versus placebo after complete resection in patients with stage 1B, 2, 3A EGFR positive non-small cell lung cancer, 83% risk reduction in recurrence or death compared to placebo. And of course, no new safety signals observed with OC. Investigators concluded the adjuvant OC should be incorporated in standard practice, and this was, of course, FDA approved for stage 1B, 2 to 3A. Now, switching gears a little bit to IMpower-010 study design. This is newer. This was also non-small cell lung cancer patients completely resected, stage 1B to 3A. And the 1B tumors had to be greater than 4 centimeters. Patient had to have a lobectomy, pneumonectomy surgery, and the tumor tissue was used for PD-L1 analysis. So these patients all had adjuvant chemotherapy, unlike the sort of the option in the ADAURA trial that had cis-pemetrexed based on histology if it was non-squam, or cis-gem, or cis-dosi, or cis-vinorelbine if it was a squam, 1 to 4 cycles. And then they were randomized to either receive atezolizumab for 1 year versus best supportive care. Now, this is all PD-L positive patients who were enrolled. And then there's a survival follow-up. So stratification was based on male, female, the stage, histology, as well as the level of PD-L1 expression based on the SP263 testing platform that we typically use for atezolizumab. Primary endpoints was investigator-assessed disease-free survival tested in patients that were PDL 1% or higher, stage 2 to 3A population, then all randomized 2 to 3A population, and then the full intent to treat population that included stage 1Bs as well. Key secondary endpoints: overall survival in the intent to treat population, disease-free survival in the patients with high PDL expression greater than 50%, and then a 3-year and 5-year disease-free survival in all 3 populations. So IMpower-010, the disease-free survival curve, as you can see, for patients PDL greater than 1%, stage 2 to 3A, which is the primary endpoint. Not a huge gap in the Kaplan-Meier curve like previously, but definitely the curve separate very early, right at about 3-4 month standpoint, and then continue to stay separate. So the median follow-up was about 32.8 months, and as you can see, the median disease-free survival in best supportive care arm was reached at about 35 months. It's not yet reached in atezolizumab, which is the blue. Stratified hazard ratio is 0.66, statistically significant and significant improvement here in patients stage 2 to 3A with PDL positive status. So when you look at the key subgroups in this population, you can see the male, female, race, performance status, tobacco use really didn't make a difference. Although I will say the current tobacco use patients seem to be going to best supportive care. I don't know, the numbers are small. There were 75 patients, but maybe I wonder if there was more pneumonitis risk with ongoing tobacco use and checkpoint inhibitor. So that's curious to me. Squame, non-squame really didn't make a difference. They both benefited from atezolizumab. The stage of the patients from 2A, 2B, 3A seems to be fairly equal benefit, lymph node status. Even patients with EGFR mutation, believe it or not, and there were 43 patients who benefited from adjuvant atezolizumab, as well as patients with ALK rearrangement benefited. You know, the yes patients cross over more in the ALK. They're sort of right in the middle. So they weren't necessarily harmed, but patients who didn't harbor the ALK mutation seemed to benefit with atezolizumab. So the question remains whether these, of course, if patients have the EGFR mutation, now we have to treat them with osimertinib. The real question is, do they really benefit from atezo more than OC? Probably not. We know we're not going to use them together because of risk of avert immune-mediated AEs. But the ALK question is definitely still out there. So when you look at disease-free survival in all randomized stage 2 to 3A population, which is the primary endpoint, again, you see that the stratified hazard ratio is 0.79, statistically significantly better in the atezolizumab group. When you look at the key subgroups here, when you look at the level of PDL expression, certainly the patients, and I think my graph is a little bit off, you can see that the patients who had a PDL greater than 50% seem to benefit the most, and then you have the patients that are greater than 1% that benefit, and then the patients who are PDL 0 sort of right in the middle of the bar. So it's unclear if patients who have no PDL1 expression, if they benefit from atezo. I would say no, based on at least this forest plot. The full intent to treat population is depicted here. The disease-free survival in the full ITT population didn't cross the significance boundary at this interim DFS analysis, so actually was not included in the approval group. Early overall survival data, it's so early and so premature. Overall survival in the ITT population was not formally assessed, but there is a trend toward improvement in survival with atezo in the PDL positive population stage 2 to 3A. So they concluded that this was obviously the first phase 3 trial of adjuvant immunotherapy to report results. Atezo improves disease-free survival in PDL positive resected stage 2 to 3A non-small cell lung cancer patients and all stage 2 to 3A patients. The OS data is very mature. AEs, which I didn't go over, are mostly expected, immune-mediated, and within reason. And this is FDA approved for this indication. So just to round it out, I did want to talk a little bit about the Pacific update. We all know this trial very well now, phase 3 randomized double-blind placebo-controlled multicenter international trial for unresectable stage 3 non-small cell lung cancers who had definitive platinum-based chemoradiation therapy, who were then stratified to receive durvalumab for a year versus placebo 2-to-1 randomization, and where primary endpoints were progression-free survival and overall survival. There were multiple secondary endpoints. So we know that this trial has been positive for a while, but this updated analyses of OS and PFS assessed 5 years after the last patient was randomized. It was really important given that we know that we have the option of rescue checkpoint inhibition at time of relapse. And so really to know that this updated overall survival, as you can see, maintains significance this far out. So the hazard ratio is 0.72. Median overall survival in the durva group is 47 months compared to 29 months in the placebo group. So dramatic and really durable long-lasting responses. So it, again, we know that this is standard of care. It's been standard of care, but this drives home the point that this is absolutely the right thing to do, and it's been the right thing to do. Updated PFS, as you can see, also dramatically different, almost 17 months median for durva group and 5 months for placebo group. So this is a high-risk population, high risk for relapse, and this is definitely the appropriate treatments for these patients. So robust and sustained PFS and OS benefits seen in patients receiving durva at 5 years, unprecedented survival seen at 5 years. I mean, 40% remain alive at 5 years, 1/3 without disease, unheard of for advanced stage 3 non-resectable non-small cell lung cancer prior to this. So, the questions again still remain, and we can discuss this more during the panel, is do all patients benefit with durvalumab? We have the question that lingers, what about the EGFR mutant subsets? Remember, ADAURA did not include unresectable patients. So this is sort of the stepchild of these adjuvant trials. What about these patients with unresectable disease after chemo radiation? If they have an activating EGFR mutation, where do they fit in? Do they get durva? Do they get OC? There's no data for that. And what about patients who had no PD-L1 expression? We know in this specific trial that PD-L1 positive patients did better, though testing wasn't part of the trial. There's a very small percentage of patients on the trial that had testing. So it's an unknown. Certainly we do it for all patients regardless of PD-L1 expression, but it would be nice to have more confidence in that particular difficult subset. So with that, I will conclude my talk, and please feel free to chat any questions throughout the talk. I'll be available to answer any questions that I can. Thank you so much for your time, and safe travels, everyone.